Investigation. Good evening, everyone. We are going to discuss how to handle an investigation station for delirium. Um, in investigation station, usually the goal is to explain what investigations are being done to the patient or their family member if patient is incapable, and to an examiner or a physician. Now, like all stations, it starts with your introduction. Hello, I'm Dr. Fayaz, one of the physicians. I understand Mr. A, B, C, etc., has been acting differently or unusual and is not his usual self. I'm really sorry this is happening, but you did the right thing by bringing him in. May I confirm his full name and date of birth? Now, with this one statement, you're introducing yourself, you're providing the family member kind of encouragement that they did the right thing by bringing them in, and you're confirming patient's identity. Once that's done, thank you. I would like to run some tests to figure out what's causing this sudden confusion. In older adults, there are many possible causes, and we want to rule out anything dangerous or reversible, like infection, metabolic changes, or a reaction to medication. Is that okay? Now, with this statement, you are providing family heads up about the management plan, which is searching for infection, metabolic causes, reaction to medications, etc. Now here you can give them a little time to process this and then continue with explaining what tests you are planning to do. We will discuss what different tests are needed for different patients with delirium. Usually it's CBC, urinalysis, urine culture, blood culture. There are a lot of tests that you can do, CT scan, everything that you think is appropriate for the patient based on their presentation can be done for the patient. Now, once you explain to them what tests you are going to do and you have given them an insight into what's going on with their family member, then you're going to talk to another physician or an examiner in this situation. Now, how you approach or how you explain the patient or present the patient to the examiner, you can start with something like, hi, I'm Dr. Fayaz or Dr. ABZ, etc. I'm going to, I just saw an elderly gentleman with acute confusion and I believe they're experiencing an episode of delirium. I would like to do the following investigations for him to rule out common, serious, and reversible causes. Now, then you can list your treatment plan or the investigation plan, what investigations you're doing. Usually, we start with the CBC. So how you say to an examiner or a doctor what you're going to do, you can just say, use medical terms here. Since it's not a patient, you don't need to make it simple. You can just use medical terms, how normally doctors would interact. You can say, I'm going to do a CBC or a complete blood count for him. I'm looking for any signs of infection, anemia, polycythemia, etc. I'm going to do basic metabolic panel and electrolytes for the patient: glucose, creatinine, BUN, sodium, potassium chloride, hydrochloride, bicarb. This will give me an idea of what's going on. Sometimes metabolic derangements such as hyponatremia, hypercalcemia, renal failure, they can present with acute confusion or altered mental status. Now, I want to do extended electrolytes like magnesium or phosphate or manganese, etc. Why I want to do this? Electrolyte disturbances are now triggers of delirium. Finally, I would like to do LFTs, AST, ALT, ALP, bilirubin, albumin. This will help in ruling out hepatic encephalopathy or liver dysfunction. I'm ordering TSH. Sometimes hyperthyroidism can present with altered mental status. Hypothyroidism, same way. I'm going to order B12 and folate for the patient, since they are known to cause cognitive impairment. I'm also thinking of I'm also going to order a urinalysis and urine culture, since UTI in the elderly usually presents with uh, confusion instead of uh, dysuria or burning sensation. I'm going to do an EKG to rule out arrhythmias, MIs, prolonged QT interval, etc. Chest X-ray can be done if patient had cough to rule out pneumonia or look for any signs of something that could be causing it, like malignancy sometimes, or tumor or mass or lymphadenopathies, etc. in the chest. CT head without a contrast. It's indicated if there are focal neurological signs present, or if patient is taking anticoagulants and they had a minor trauma, or in cases of head traumas, you can consider CT. If patient with head trauma is presenting with delirium or confusion, CT is indicated. Now, at the end, you summarize to the examiner, since we are summarizing to the examiner in medical terms. So you can say, to summarize, I ordered tests, or I ordered blood work to assess infections, metabolic, neurologic, endocrine causes of acute delirium. The most likely cause here is a UTI supported by elevated WBC in a positive urine culture. I would also correct the patient's hyponatremia and monitor for potential renal impairment. CT ruled out stroke or bleed, and ECG is reassuring. I will now initiate appropriate management and reassess regularly using the confusion assessment method. The confusion assessment method is used in hospitals. It's a four question: acute confusion, yes or no, that gets points. Patient has fluctuating, the confusion is fluctuating in nature, yes or no, it has another point. Inattention, yes or no. Agitation, yes or no. These are like 4 points that they use to assess if patient is in delirium. Once you have summarized to examiner, now same way you can summarize to patient, son, or the son of the, or a family member that's there. We have done some tests to see why your father is confused. It turns out that he has a UTI or a bladder infection, and his sodium level is low, which can both affect the brain. The good news is that these are treatable. We are going to start antibiotics and monitor his blood chemistry closely. Once that's done, that's your station for acute delirium investigations.